Next speaker is Dr. Miles Behan from the Royal College of Physicians of Edinburgh. Miles is a senior consultant cardiologist. We especially thank him for taking over this lecture. He'll be talking about new oral anticoagulants.
So, what we're going to talk about today is the limitations of the old oral anticoagulants. So limitations of low molecular weight heparin and warfarin. We're then going to give some background to what these new oral anticoagulation agents are, their characteristics and their properties, and then the practical challenges that we will face when we come to deal with them in terms of laboratory assessment of these agents, but also then the clinical problems that will be associated with them. Finally, then, how to manage the bleeding when you're on these drugs. So, if we think originally about the old oral anticoagulants, what are the problems with them? Well, first of all, with unfractionated heparin and warfarin, you need to monitor the therapy regularly. If you're on unfractionated heparin IV, you'll need to have your APTT checked regularly. If you're on warfarin, then you'll have your INR checked at least once every 4 weeks, but more as your therapy starts, or if your INR changes because of interactions. The new low molecular weight heparins were a great advance in the fact that for the treatment of clotting problems in patients with cancer. However, the fact that they are an injection has put some patients off. And then particularly for warfarin, there are a lot of drug-to-drug interactions which can cause the INR to be quite variable. So if you were to make a new oral anticoagulant, what would you want? You'd want an anticoagulant that had a predictable response. There were few drug interactions. It could be taken as a tablet. There was no need for monitoring. It was simple dosing. It would have a short half-life, so it would be get out of the system quickly once you stop it, and there would be an antidote to treat you if there was bleeding. So these new oral anticoagulants have been developed, and they've been described as a gift from nature. The fact that the antithrombin agents have been studied on Herudin, which comes from the saliva of a leech, and the anti-factor Xa agents have come from this tick anticoagulant peptide. And these are the there's 4 agents currently. There are 3 agents which have been approved by the FDA. Edoxaban is still waiting approval. You can see that rivaroxaban, apixaban, and edoxaban are anti-factor Xa agents. Dabigatran is an antithrombin agent. And so far, their indications are similar to warfarin in the fact that they're indicated for stroke prevention in non-valvular atrial fibrillation, and they're indicated for the treatment of PE and DVT. They're not indicated for other indications for warfarin, such as valvular heart disease or prosthetic valve. So it really is just for non-valvular AF and venous thrombosis. The characteristics of the drugs, and you can see that actually they have a very short time to act. So they're, if we look, you can see that the dabigatran and rivaroxaban and apixaban, they're active very quickly. So normally that means that, rather than with warfarin, where you might be waiting for 5 days for it to become active, these things are active within hours. So there isn't a requirement for bridging with unfractionated or low molecular weight heparin. So they have a very rapid onset of action. Dabigatran is excreted renally, so caution has to be taken in patients who have impaired renal function. And also they have a short half-life, so you can use them up to and quite close to surgery before stopping them. But I'll come more to this in a moment, but these are the specific properties of them. They have a rapid action, and they have a short half-life, and some of them are excreted renally. They do interact with some liver enzymes. Their interactions are, you can see that dabigatran here, it interacts with some antifungal agents, but particularly it does interact with amiodarone and verapamil. And that's probably going to be the most relevant for clinical practice. Likewise, the factor Xa inhibitors, so apixaban, rivaroxaban, they interact particularly with clarithromycin, and that's something that will be clinically problematic. So what are these practical challenges for these new drugs that are emerging and are going to become more and more popular? Well, there's going to be some laboratory issues which we can discuss about how you will assess their effect and measure and what effect they're going to have on the hematological assays that we use. And then there are also going to be these issues applied to the patient. We'll come to this in a moment, but when you take warfarin, you can have your INR checked, and then we can tell that you are taking the drug. It's going to be much more difficult to assess compliance with these drugs. Also, if the patient is coming into hospital and they're bleeding, how do we stop the bleeding? If you're on warfarin, you can be given factor Xa or other things, whereas at the moment there's no antidote for these agents. And also, how do we use them in specific patient groups, particularly the elderly or patients with renal impairment or hepatic impairment? And can they be used in pregnancy? And the answer at the moment is no for that one. And then finally, as physicians, you're going to be asked a lot by your surgical colleagues or dentists, when should you stop these agents if the patient's on them before you pull their tooth or before they have a colonoscopy? And we'll come to that. So the lab challenges. First of all, why do we need to measure the effect of these new agents on the laboratory parameters? Well, it's useful to be able to tell, is the patient taking the drug? Secondly, you want to know how much drug is on board, because is an anticoagulated patient bleeding because they've got too much of this agent on board, or are they having recurrent thrombosis because there's not enough on it? And likewise, we also might want to move a patient from one of the new oral anticoagulant agents to warfarin or vice versa. So you might need to know what effect it has on hematological assays. And if we look here, this is a complicated slide, but effectively, the coagulation assays such as APTT and thrombin time and INR, they're all affected by dabigatran. And from a clinical hematology hospital point of view, this is important because if a patient comes into hospital and has a coagulation blood sample sent off without people realizing that they're on dabigatran, the lab will phone you up and be very concerned and say, is this patient got DIC or something quite catastrophic going on because of this slightly odd effect that dabigatran has on all the coagulation assays. There are ways of measuring dabigatran, and there is a direct assay, and also there's this equine clot time. However, both these ways of measuring, we can measure dabigatran is there, but the level, we don't know what it means, the fact that certain levels, we're not sure what to do with the data other than the fact that we can't measure this on board. Rivaroxaban also will affect your blood tests, so it will prolong the PT, it will affect the APTT, and also factor Xa activity. So rivaroxaban can be assessed that it's present. So the lab is going to be difficult because what we can see in the laboratory tests is that you'll be able to assess that there is an effect on the blood tests, but it's difficult to know what that effect actually means. And then the clinical challenges are going to be more difficult. And that's particularly for things such as compliance. Because like I said, when you're taking warfarin, you can assess that you're on warfarin by checking someone's INR. For these agents, it's going to be more difficult. Also, there's some agents like dabigatran and apixaban, the two of them are actually a twice-daily preparation. And we know from twice-daily preparations that patients struggle to achieve more than 60% of compliance when you take the tablet twice a day. And also, what do you do if you miss a dose? Patient education and counselling is vital. One role I found particularly important for these drugs and very useful is for DC cardioversion for atrial fibrillation. So normally if a patient is in atrial fibrillation, we want to cardiovert back to sinus rhythm. We have to load them on warfarin, check that their INR is therapeutic for at least a month before the procedure and a month afterwards. And it can sometimes take 2 or 3 months before the INR is therapeutic. With these drugs, we are able just to give the patient a 4-week course, or an 8-week course in total, 4 weeks before the cardioversion, 4 weeks after the cardioversion, and then you can stop the drug, and there's no need for warfarin. So you can make DC cardioversion very quick as an outpatient procedure. problem is, the patient may turn up and say they've been taking the dabigatran, and if you don't know if they have. So now we have to make patients sign a compliance statement saying, I've taken this dabigatran religiously twice a day for the last 4 weeks, and will continue to do so after the cardioversion. So it's very important to make for patient education about their doses. And also, there's different drugs, like I've said, we've got apixaban, dabigatran, rivaroxaban, and there's different indications for each and different doses for each. Rivaroxaban is a different dose whether you want to be treating someone for stroke prevention and atrial fibrillation, or you want to treat them for the prevention of DVT. So it's going to be difficult. What's recommended in Britain is that one institution just takes on one of these agents rather than having different agents available to make things more simplistic. And we can see then that, say, for rivaroxaban, if you have renal impairment, if you have mild renal impairment, you don't need to change the rivaroxaban. But as your renal function decreases, you do need to decrease the dose of rivaroxaban. However, it requires an accurate assessment of renal function. So the Cockcroft-Date formula needs to be used so that you're not underestimating renal function in elderly patients. However, generally, there's no dose adjustment for the elderly or those with low weight or female sex. So it's not recommended for children, and they're not recommended for pregnancy. Also, the patients must be taken, the tablets must be taken with food, because dabigatran particularly causes quite a lot of stomach irritation. If you're a hematologist, when are you going to be contacted about these drugs? In fact, when are you going to be contacted by other clinicians about these drugs, whatever physician you are? It's going to be on things such as, when should you start the drugs, or how should you convert someone who's on heparin onto a novel oral anticoagulant, or when should you stop the drug before surgery, and when then you need to restart it. These are complicated questions, and we'll go through them now. But probably the best thing is that each institution has well set up protocols so that people are aware of how to proceed. If we take rivaroxaban, for example, one of the agents, if you're converting rivaroxaban to basically heparin, what you would do is you're giving low molecular weight heparin. Rivaroxaban, they have their 9 o'clock dose, and at the time when they would have their 6 o'clock dose in the evening, you'd then start the IV heparin, or the low molecular weight heparin, so the subcut heparin. And likewise, if you're changing them from heparin to rivaroxaban, then you start rivaroxaban. Basically, if they're going to have their low molecular weight heparin at 6 o'clock in the evening, you'd start rivaroxaban at 4 o'clock in the afternoon. Likewise, if you're converting someone from warfarin to rivaroxaban, you're going to wait until they're until their INR comes down to the upper limit of the therapeutic window that you want. So if someone is being treated with an INR between 2 and 3, as soon as the INR drops to less than 3, then you'd start rivaroxaban. And if you were converting someone from rivaroxaban to warfarin, you would actually start warfarin at the same time as the rivaroxaban until their INR is therapeutic. So the other common question that we'll have is things such as, when is it safe for this patient to have an operation? How many days before their angioplasty or whatever should we stop their rivaroxaban? And at the moment there is no obvious consensus. However, it's sensible just to take a sensible, practical approach to this. So effectively for the 10A inhibitors, so the apixaban and rivaroxaban, effectively, if you stop it 48 hours before the procedure, even if they're at high risk of bleeding or there's renal dysfunction, you should be okay. However, if you're worried about the patient from a thrombosis point of view, you can stop it at 24 hours beforehand. Dabigatran, because of this renal clearance, probably if they have renal failure, you should stop it 3 days beforehand, but then you can come down less, or 4 days beforehand. But then if they've got normal renal function, they're low risk of bleeding, you can stop it just the day before. So, if someone is on rivaroxaban and they're coming in to have some minor procedure, such as a dental procedure or a colonoscopy, then what you would do is you would stop the rivaroxaban, and then make sure that there was a 24-hour period before they had their procedure. And then as soon as you are happy that hemostasis was achieved, they can restart the rivaroxaban about 4 hours afterwards. However, if they're coming in for major abdominal surgery or something you're more worried about, you would stop it about 24 to 36 hours beforehand. If there's renal impairment, then you're always going to sort of err on the side of caution and probably stop it earlier. However, as we said, because their half-life is quite predictable, we can tell that if you're stopping it 24 or 48 hours beforehand, they're going to be therapeutic up until just before their surgery. So there probably isn't a need to bridge them beforehand with low molecular weight heparin. And then just effectively, they are very rapidly acting. So they will be reaching their maximum concentrations within 2 to 4 hours after post-ingestion. So you can restart them quite soon after surgery, as soon as the hemostasis you're happy with. However, supposing they've had colonic surgery or something, you're going to be careful to check that they've not got gastroparesis and they are absorbing your agents. At the moment, there isn't a reversal agent. So I'm going to come back to the slide in a second. But there is obviously a concern if someone's going to present to your hospital and they're bleeding on dabigatran. What you do is you cannot reverse it. Looking at the trial data so far, it seems that probably it may not be as big a problem as we think. There's a lower incidence of intracranial hemorrhage on dabigatran compared to warfarin. And there doesn't seem to be an increase in major bleeding in those who've undergone emergency or elective surgery when on dabigatran and warfarin. There is no antidote yet, although we have some early data. People are working very fast and hard to try and find an antidote for these agents. Effectively, what will you do when someone comes in and they're bleeding? You're going to find out when they took the last dose. You're going to make sure they stop the treatment for them. If they took the dabigatran or the other agents within the last 2 hours, you can give some activated charcoal to stop any more of it being ingested. And then you would do the standard resuscitation measures of fluid replacement, transfuse if necessary. You'd want to see their hematological assays quickly, the PT and APTT, because once those have returned to normal, you can be sure that the agent is out of the system, but also it might give you an idea of how much agent is in the system. If they were only having mild bleeding, and you were happy to, you could just use local hemostatic measures, such as epistaxis that was being controlled, or a surface wound, then probably just pressure and delay the next dose of your new oral antibiotic until the bleeding stops and you're happy that it was stopped. It becomes more difficult, obviously, if the bleeding is more severe. And then so you're going to do the local measures, resuscitate, but then you're going to consider giving FFP or platelets. You might give IV tranexamic acid, and then you can consider some of the use of the prothrombin complex concentrate. And then if it's a life-threatening bleed, then you're probably going to give the PTC anyway. And certainly if they were on dabigatran, you might consider hemofiltration because it's renal excreted just to get rid of it quickly. But it's important to say that vitamin K and protein are not going to cause any, will not reverse it. Likewise, normal transfusions of platelets with FFP. So the management of bleeding in these agents has not yet been fully decided. However, at the moment, it's going to be a practical approach moving up through. You might have to sort of treat the bleeding as normal, and then consider, depending on how severe it is, whether you go on to dialysis with dabigatran and get it with PCC. There is some, just as I mentioned, though, there is some work suggesting, this is a paper that's just been published very recently, and there is an antidote to rivaroxaban at the moment, although this has not been tried in man successfully yet. Also, most of our information on these drugs so far has been from trials, although people are now starting to use them more and more worldwide. And so far, there's not been any major side effects that have come out of the blue. The handling of these agents in pregnancy is unknown, so at the moment they're not recommended in pregnancy. And there's been a slight concern with dabigatran, possibly this idea that it might increase your risk of myocardial infarction. And that's being examined by the FDA at the moment and in some registry data, although that's not clear. So, coming from where I am in Scotland, these are the signed guidelines at the moment. So this is for prevention of stroke in patients with atrial fibrillation. This is non-valvular atrial fibrillation. So it's recommending that all patients who have a CHA2DS2-VASc or CHA2DS2 score of greater than or equal to 1, and that's something we heard about on Monday, so that's a risk that you get a point for diabetes, a point for congestive heart failure, a point for hypertension, a point for being female, and also importantly, you'll get a point for being over the age of 65. So effectively how we take these is anyone over the age of 65 with atrial fibrillation should be anticoagulated. And the first line should be warfarin with a range of INR of 2 to 3, or a newer anticoagulant. And then just a patient should be reviewed once a year, have their risks and benefits assessed. But in Scotland we're saying it's warfarin first, and the newer oral anticoagulants for patients who are unable to tolerate warfarin, and whether that is they have very erratic INRs or they have a true allergy to warfarin. But otherwise, we would recommend warfarin first, and then the newer oral anticoagulant agents. And in Lothian, which is the health board that I work in, here we've got this consensus, and we've chosen a Pixaban, which is a twice-a-day dose. And we felt that gave us the greatest risk benefit. But we feel that patients who have a good INR control, that means that their INR is between 2 and 3, greater than or equal to 60% of the time, should continue on warfarin, and that is still probably superior to the new agents, well-controlled warfarin. However, if for some reason warfarin is not tolerated or there's erratic INR control, then the novel oral anticoagulant agents should be considered. So in summary, basically we have these very new exciting classes of oral anticoagulant agents. These drugs are very convenient, so they will become very popular. But there are going to be some challenges associated with them as any new therapy is brought on board. First of all, it's going to be important just from when a patient comes into hospital, if a blood test is taken, we're going to have pathways set up to say this patient is on the rivaroxaban, so it doesn't scare the lab. We're going to have to educate medical and nursing staff on how to avoid any problems with them. We need protocols set up because there are complications in the fact of switching from starting the tablets, switching between therapies, and also when to stop and start them around the times of surgery and intervention. And also then we're going to need to know how to understand the bleeding risk of these, and we'll await whether I'm sure an antidote will be available soon. Thank you very much.
Thank you very much, Miles. And we'll allow for one question only because we have to be stuck by. So, any question or comment? So, all clear. Thank you very much again, and we'll move to the next.
One question.
Yeah.
Nearly got away with it.
Why these new oral anticoagulants really not used in valvular? What is the mechanism? We want to understand why. Why only non-valvular? Thank you.
That's a very good question. So he's asked, why are they only licensed for non-valvular atrial fibrillation? The reason is that when they looked in trials, and they've done them in trials with patients with rheumatic mitral stenosis, patients with metallic heart valves, they found that these new agents actually increased the risk of thrombosis in comparison with warfarin. So they weren't as effective as warfarin when dealing with patients who have valvular heart disease. So they should be avoiding rheumatic mitral stenosis and patients with prosthetic valve.